So this time I'm going to be talking about a relatively controversial, topic, which is only based on guidelines. So who should get IVC filters? So we talked about, VTE being the significant cause of morbidity, mortality, and the mainstay of treatment is anticoagulation. Surgical cable interruption was the first thing that came to prevent pulmonary embolism in the 1900s. And because of the technology advances of IVC filter design, there was a shift of practice. So basically, that contributed to increase in the use of filters. And in the 2014, there was around 100,000 filters placed in the US. So as you see here, there are so many guidelines from different societies about indications of filter placement. And these are guidelines, as you know all, that there are no level 1 evidence about indications for filter placement. And there is lack of randomized trials. So why do we need guidelines? There are so many unanswered questions regarding the efficacy of filter placement. There is lack of good level 1 evidence in the literature. There's complications, as we know, associated with filter placement. IVC filter placement is overused in the US and around the world, and the retrieval rates are still low, even like with good clinical follow-up and in major academic centers, it's still low. So how do we decide if we place a filter or not? So basically, it's about risk-benefit ratio, knowing the society guidelines, and using the medical judgment. And also knowing in your own practice, what's the filter retrieval rate. So I'm going to summarize some of the society guidelines, and as you're gonna see, based on different case scenarios, different societies might suggest the same thing or different indications. And if you read through the guidelines, it's always like suggesting or, if it's appropriate or not, but they don't really use strong words in general because there is no strong evidence. So basically in acute PE cases, when there is a contraindication to anticoagulation, the SIR suggests an IVC filter placement based on specific considerations. The strongest recommendation is from Chest and NICE, which they recommend IVC filter placement. The American College of Radiology, they say it's appropriate. And the European Society of Cardiology also recommends it. And in the consideration, you have to think about the ongoing VTE risk, usually cardiopulmonary status and reserve, the hemodynamic response to PE and the location of the PE, presence of DVT and the extent of it, if there is any residual DVT, and the expected duration of contraindication to AC. So basically, for example, if you have a patient with subsegmental distal PE and you get a request for filter placement, what do you do? Like, these are difficult cases. The guidelines are in general suggesting or recommending filter placement, but in real life, is it the right thing to do to the patient? So the next case scenario is acute DVT with contraindication to anticoagulation. Again, you can see that the SIR suggests a filter placement based on clinical risk factors. The ACR says it's appropriate. Chest and NICE and ESC, they recommend filter placement. It's around the same considerations. Usually the consensus, it has to be a proximal DVT to be appropriate for filter placement. Anticoagulation should be resumed as soon as possible because that's what's going to help the body to get rid of the clot instead of just preventing the clot to go to the lungs. And as you know, the filters will prevent large clots to go to the pulmonary arteries. Another case scenario is acute VTE, whether it's PE or DVT, with ongoing anticoagulation in patients who develop contraindication. And now you can see that the society guidelines go back to only SIR and ACR and a few other societies. And they suggest IVC filter placement based on clinical risk factors or if it's appropriate in the ACR guidelines. The other case scenario, which makes it a little bit more complicated, is the same as the one that I mentioned, acute VTE with ongoing anticoagulation, that the patient had an extended period of treatment, but now we have a contraindication after completion of an acute phase of anticoagulation. And in this case, you can see that the SIR suggests no IVC filter placement with specific exceptions. So it goes back to the assessment of risk-benefit ratio. Another case scenario is ongoing therapeutic anticoagulation with recurrent VTE. And again, you can see that a few societies considered this case scenario, including the SIR and ACR, as well as the AHA. In the SIR guidelines here, you can see the contradiction in the recommendations, which makes it even more difficult. In the SIR, they suggest no filter placement with exceptions. They really talk about what's the definition of failure of anticoagulation. Is it because of the dosing or the patient not taking the medications? So it's hard to distinguish also if the residual thrombus in case of DVT is from previous, clot or pulmonary embolism, and is it appropriate to place a filter in that case? There are also many reasons for failure, as I mentioned. You can switch also to a different anticoagulation or dosage and see if that's gonna make a difference. And in the SIR guidelines, they suggest placement of filter if there is an objective confirmation of VTE recurrence and they don't find any modifiable issues related to anticoagulation. So as you can see, the guidelines get softer and softer in different case scenarios, and it makes the clinical judgment even more difficult. This is an easy thing, probably the easiest, the acute VTE with therapeutic anticoagulation. All the societies recommend against routine filter placement in general because the anticoagulation is the main treatment option, and the filter has risks, as we talked about. Another case is acute VTE with advanced therapy during the CDT. So the case from today, they used, a protective device. So the SIR and the ACR, they suggest considering an IVC filter or retrievable filter or other devices that can probably protect, the clot to move into the lungs. In PE cases, and if the patients are unstable, they suggest multidisciplinary evaluation and chart documentation in DVT cases and high risk clinic, and in addition to high risk of clinically significant procedure-related PE, also they suggest placement of the filter or at least protection and then removal of the filter. There was this RCT of 141 patients who had a proximal DVT and were getting a CDT. They randomized the patients into IVC filter and no filter groups. Not surprisingly, PE was detected in 1.4% in the filter group compared to 11 in the no filter group. And the placement of the filter was associated with no complications. Again, this is not a clinically relevant endpoint probably. The mortality or morbidity would be a better evaluation or endpoint in these cases. It's not surprising that the group that didn't get any filters had more PEs detected, but did that really change the clinical scenario or really increase the patient's morbidity or mortality? These are difficult scenarios that we deal with every day, whether in clinic or when we get a trauma patient. So basically, a trauma patient without any known acute VTE, the societies recommend against use of filters. The ACR, they suggest retrievable filters or, surveillance ultrasound when the patients are having major surgery, such as neurosurgery, with the possibility of extended immobility without non-acute VTE. Also, the SIR recommend against filter placement. And as we all know, we deal with this scenario every day. When we get requests for filter placement on such patients. Other guidelines, basically, they talk about suggesting filter retrievals when the risk of PE is mitigated or the patients are no longer at risk of PE. If the patients have permanent IVC filters and there is no risk of additional PE, they suggest against filter retrieval. These are from the SIR guidelines. Just because, again, weighing the risks of filter removal or removing permanent filters compared to retrievable filters. We all know the IVC filter complications. I always like to get the filters out if possible. And, if the benefits of removing the filters are higher than the risks. As we know, having a filter will increase the risk of DVT in patients. A lot of referring physicians also don't consider that, and they think that the patient has a filter already, so the patient is protected. They don't even resume the anticoagulation, even on patients who have a high risk of DVT. And then the patients come with, caval thrombosis or bilateral iliocaval thrombosis, or even worse than that, chronic, DVT and PTS eventually. The guidelines usually suggest, having a structured follow-up program, but even in big centers with a structured follow-up program, the rates of retrievals are still low, whether because of the patients don't follow up or it's difficult to reach out to patients, and so many other reasons. Planned IVC filter retrieval is suggested against routine pre-procedural. So basically, they're suggesting against routine pre-procedural imaging or labs if you have a planned IVC filter retrieval. We still get non-contrast CTs if we think that the filter might be very tilted or if the filter was placed long time ago, but the society suggests against it. Thank you, and I will take any questions.